Officials have recorded a worrying increase in COVID-19 cases across much of South Africa. Mkhize says the Free State, Gauteng, Northern Cape and the Northwest are of particular concern. However, he did add that every province, with the notable exception of the Eastern Cape, has at least one district of concern. So these districts that have been flagged by the National Institute for Communicable Diseases as under observation due to an appreciable rise in the 14-day average percentage change will be monitored. Meanwhile, esteemed epidemiologist Prof Salim Abdool Karim says we are likely to experience a third wave of COVID-19 infections during winter when temperatures drop and people's immunity will be weakened. Salim Abdool Karim was recently appointed as a member of the World Health Organization's Science Council, and he joins us now. Very good evening to you, Professor Karim, and thank you so much for speaking to us, and congratulations.
Thank you very much, Sophie. So very good evening to you and all the viewers.
How exciting is this for you, just in light of where we are as South Africa? And I remember various conversations that we've had about our modeling of our own trajectories and how you've had learning experiences of mistakes made, of calling it right at the same time. So take me through this, the importance and the significance of your appointment to this council.
Yes, so, science is all about learning. Science is all about us, trying, making mistakes, learning by error, succeeding every now and then, and moving forward, always moving forward. So the World Health Organization has been going through several changes, and among those changes has been the effort to try and put science front and center in the work of the World Health Organization. And as part of that, the new, it's not so new anymore, Dr. Tedros, the Director General, has created a science division and has appointed a chief scientist. It's not COVID only, it's for all aspects of health. And one of the things he's created is the Science Council. And the idea is that he's brought together 9 of us from various parts of the world, different disciplines, different areas of research or different areas of experience. And we've come together. We are chaired by Dr. Harold Varmus, who won the Nobel Prize for Cancer. And the idea behind this Science Council is to provide high-level advice to the Director General. And it's to look at the scientific landscape. It's to see what new things are emerging, what new technologies, what new findings that may impact health, so that we can advise the World Health Organization about strategic initiatives that it needs to consider so that it can be better prepared and can exploit these new scientific benefits for health.
Professor Karim, no doubt some of the conversations that are taking place at the moment are the various variants. You have, as I mentioned, said that South Africa could possibly face a third wave. So what are the conversations being had about what is likely to happen? The variant in India, its presence here in South Africa, how worried should we be, especially in light of, fears of a third wave?
So I think that we need to start off with, the fact that we actually don't know if and when we're going to have a third wave. So it's based mainly on speculation and projections. So if we had to look at the current situation, we've seen only a handful of countries have had a third wave. I analyzed a few weeks ago 7 countries that had a third wave. And, the problem is that none of those countries had a first and second wave that was like ours. So it was hard to extrapolate from those countries. But the one observation that is worth noting is that in all 7 instances, the third wave was worse than the first and second waves. I think the big difference is that we have a new variant. And because of the variant, our second wave was very different from all these other countries' second wave. And so we're not really sure. We can't really predict based on what we're seeing elsewhere about when and how and if this third wave is going to occur. I think it's reasonable to expect that we will see a third wave. The chances are that we'll see it when our behavior creates the conditions for the virus to spread.
Okay, so...
Sorry, go ahead.
Okay, so I was going to talk about the B1617 variant in India, and as you say, our behavior is important as to whether or not it'll spread, and it will be as much as creating a third wave in the country. But I also do want to understand, what have you learned from what they called seroprevalence in South Africa, what we've seen, and can that protect us from, things getting worse?
Yeah, so let's just for a moment look at the B1617 variant that was first described in India and is rapidly spreading in India. That particular variant has a mutation in the key part of the virus that is the same as the mutation we have in the 501YV2 variant that we've described here in South Africa. And that's a mutation in position 484. So there's a lot of similarity between the 617 and the 501 that we have in South Africa. Those two viruses have quite a lot of similarity in terms of those mutations. The B1617 from India has an additional mutation, and that additional mutation is similar to one in California, whereas the South African 501YV2 has two additional mutations that are quite severe and quite substantial. So I think all in all, if there is the introduction of the B1617 variant, I'm quite doubtful that it will spread to any significant extent because it's so similar to the virus we have here. So I'm not concerned that it's going to cause the third wave. In fact, if anything, I'm concerned that South Africa will have a new variant, not one that's come in from outside of our country, but one that's created within our country. And the reason is, of course, we had the first one, the 501YV2, that was generated. Yeah, and so we think that that would be a major source of a problem, because if such a new variant is created and if it can escape immunity, then it could cause a massive amount of infection. So when you talk about seroprevalence, we're talking about the proportion of the population that has been infected already. In South Africa, we don't have accurate estimates yet. We have estimates from a range of different sources, but they're looking at it, it's probably somewhere between 40 and 50% of the population has had some level of protection.
So what is the discussion in the scientific community, Professor Karim? Because I believe that the Indian variant is being looked at with interest, not necessarily being seen as a variant, even though it has 13 mutations. But I want to understand why, because there is obviously keen interest in what is happening in Brazil, in the UK, and as you say, we should be looking closely if we'll have a different variant. So paint to us how the disease behaves in such a way that something that can be deadly in one country can be almost innocuous in another.
So it's fascinating when you look at the way in which this virus is spreading. I think the one thing we've come to understand, that if a variant emerges in one country, it very rapidly spreads to many countries. If you look at the original virus from Wuhan, rapidly spread to almost every country. Now you have a situation where the 501YV2 variant, the one that we described here in South Africa in December, it's now in 67 countries throughout the world. Just to give you some idea of how interconnected the world is, that a variant created or spreading here locally is now widespread in many countries. And so that's really a challenge. And the reason that underpins that is the fact that over time, our populations and all of us aren't able to maintain our prevention measures as we should. We aren't able to sustain, mask wearing and so on. So as we get complacency, as immunity wanes, this virus comes back. The opportunities come back for the virus to spread. And so at this point, we are looking at a situation where many of these variants are now in multiple countries. So this idea that, a variant was only here or only there is no longer the case.
Okay.
Are they important? Not particularly, except when they are variants of concern, which you've already touched on. There's these three variants, the one in Brazil, South Africa, and the one in the UK.
So now let's look at what individual countries are doing and how this impacts, especially when it comes to vaccine rollout. South Africa, there's been various lamentations about the slow pace thereof. But there have also been various scenarios that have been projected for the third wave, including that there could be between 8,000 deaths and 70,000 deaths if there is a third wave. What informs this kind of modeling?
So the modeling is done with varying assumptions, and pretty much, one guess is as good as another in many of these instances because so much is unpredictable. So there are two key underlying assumptions. The first is, whether we're going to get a third wave, when we're going to get it, how severe it's going to be. It's going to be based on two things. The first is our behavior. If we create the conditions for a virus to spread, if we have mass gatherings. Remember when we were dealing with a pretty good situation in November until the university students and the high school students decided that they are going to have their parties. And that's what created the conditions for our second wave. So if our behavior creates the conditions for the third wave, largely through super spreading events. Remember, about 80% of new infections occur from just about 10 to 20% of the population. So these super spreading events are central. The second is whether we get a new variant. And the new variant is more likely to emanate from our own population than it is to come from the outside. We will get variants coming from multiple countries, but a variant that has immune escape is the one we're worried about. So based on our behavior and based on whether there's a new variant, that will heavily influence if and when and how severe our third wave will be. So
there's been a continual heavy emphasis on non-pharmaceutical interventions and the observation thereof. All that said and done, can the third wave result in fewer infections? And what would be the effect of smaller clusters of infections?
Yeah, I think you've touched on what is a key factor. So very few countries, we should deal with the myth that's often posted, if we vaccinate people, we won't get a third wave. That's simply not true. And the reason for that is to avoid a third wave, we would have to vaccinate a very high proportion of the population, probably in the region of 70, 80%, which very few countries have been able to achieve. So right now, there's probably about 3-4 countries that have achieved that. Israel, Bhutan, maybe Gibraltar. The UK and the US are still far behind, but they are heading in that direction. So very few countries have vaccinated such a high proportion that they can avoid the third wave. So that means the rest of the world, we're going to have additional surges, additional waves. The goal of vaccination is to now try and protect the most vulnerable. And in our case, to try and protect the healthcare workers, because when people are sick, they are the ones, the healthcare workers get exposed and then they get sick. And that's when they are most needed. We really need our healthcare workers during a surge. So vaccinating them is critically important. And then the elderly, because the elderly are the ones who mostly need hospital care and who have severe outcomes. So if you vaccinate those two groups, we have a pretty good position in that a lot of people who would otherwise have severe disease would be protected. So that's the way we look at it. The vaccinations will achieve that. But to actually slow down the spread of the virus, we're going to have to use our prevention measures, our social distancing, our mask wearing, try and staying outdoors as much as possible. These are key things. If we follow that, we can keep this virus at bay and keep it under some level of control.
Dr. Tedros mentioned this again, the problem of inequality when it comes to access to vaccine doses. This has been something that he has mentioned over and over again, and yet there's this criticism against South Africa about what is seen as the slow speed of vaccination or the rollout, but it's also because of a lack of supply. Please talk to me about this and also what we've seen internationally. There are countries who had vaccine doses in higher amounts, who vaccinated their communities. And I want to look at India as an example, but then we have this unfortunate incident that we've seen now of a mutation that has led to a huge spike in deaths.
Yeah, I think when you look at the vaccine situation as a whole, those countries that invested in actually making their own vaccines and manufacturing their own vaccines, they have done the best in terms of vaccination coverage and access to vaccines because they made those vaccines. The US, the UK, Russia, and China. Those are the 4 countries that have the most number of vaccine doses. So you look at, there's a direct correlation between the ability to make vaccines and manufacture vaccines and access to vaccines. If you can't manufacture vaccines, you've got to join the queue. And you join the queue, and of course, richer countries can pay higher prices, they can jump the queue, they can do all kinds of things. And so we have to understand that of the 1 billion doses that have so far been given out, that just over 70% of those doses went to just 10 countries. So you have basically a situation where the rest of the world, there's about 190 odd countries in the rest of the world are making do with a small number of doses. And so we are part of that. We are part of the ones that have only a small number of doses. Now, that's being remedied because in South Africa, we now are in a more fortunate position that we have signed contracts and we're buying large numbers of doses from Johnson & Johnson and Pfizer, enough for the phase 1 and 2 of our vaccine rollout. So now we don't have a problem of purchase, we have a problem of as it becomes available and delivery. So to me, the big challenge is that we've got to stand together to get these vaccines out, to get these millions of doses that are going to arrive, to get them into arms, because that's not going to be dependent on the government or in the private. It's going to depend on all of us. It's going to depend on you. It's going to depend on me. It's going to depend on all your viewers. We've got to do this together. Okay. It's our joint responsibility.
So, Professor Karim, what has also been problematic is the lack of data on these vaccines, because we understand that not all vaccines are made equal. There is, let's take the Seychelles, for instance. They were using Sinopharm, and they'd pretty much vaccinated their population when there was an emergence of new cases. We have received Pfizer, which is said to be 95% in terms of the protection that it offers, but then there's the J&J, which offers only 64%, but has the advantage of a single dosage. Is this part of the reason why there is vaccine hesitancy? How should we be framing these things in our mind, all of this information, and taking it into account, especially when we talk about retrogenic or side effects?
Yeah, I think we're beginning to understand that not all the vaccines are equal. They all seem to do reasonably well when it comes to severe forms of the disease, although the data from that is not always available for every one of the variants. But South Africa is in a slightly different situation because we have a variant, and that variant is able to escape immunity. It escapes natural immunity partially, and it can escape vaccine immunity partially. So now, when we look at any vaccine, we want to have some evidence to support the fact that the vaccine works against the 501YV2 variant. Now, we're pretty confident that the Johnson & Johnson vaccine works in our setting. Why? Because the trials were done here and they were shown to be effective. So we saw 64% efficacy here. The same vaccine was 68% efficacious in Brazil and 72% in the US. So pretty similar levels of efficacy across the three different kinds of virus, the three different variants. Similarly, with Pfizer, because the initial clinical trial of Pfizer included South Africa, we know that the vaccine is effective against the 501YV2 variant. We saw new data come from Qatar that also shows that it's effective against this variant. So we want to make sure that we've got a vaccine that will protect us from the variant. And there are a few vaccines that do that. Some of the vaccines don't do that in the same level of efficacy. For example, we see with AstraZeneca vaccine, it's 70% effective in the UK, but only about 10% effective against the 501YV2 variant in South Africa.
Professor Karim, just as a final question before I let you go, then what is the importance of this efficacious versus transmissibility, especially within the context of vaccination?
So there's a difficult question that we need to answer, which is when a person has a vaccine, has been vaccinated, and they become infected, and we know, people who've been vaccinated do acquire infections because none of these vaccines is 100% efficacious. When they acquire infection, do they transmit? That is a question that's really important. Now, it's been difficult to answer that question because you need to have secondary attack rate studies. In other words, you need to look at people who've been vaccinated and the people they come into contact with versus those who are not vaccinated and the people they come into contact with. So it's quite a difficult set of studies. And so we've been using proxies to measure that. We try to measure the amount of virus in the nose and so on. But really speaking, the question about whether vaccinated people who get infected, whether they transmit the virus and to what extent, that's an unanswered question. And it's an important question that needs to be answered because our approach to herd immunity is based on low levels of transmission among vaccinated individuals.
All right, thank you so much. And thanks for your time, and hopefully we'll have time to answer some of these questions. Professor Salim Abdool Karim, who was recently appointed as a member of the World Health Organization's Science Council.